Welcome to Health Policy, Organization, and Finance. This is your Week 5 video. Week 5 will be talking about the last two major insurance programs in the country. We did Medicare and Medicaid, and this week we're going to talk about employer-based insurance and the federal marketplace. I put these topics together even though they probably could be separate because they have a lot of the similarities between them. I'm not going to go over the history of why we have employer-based insurance in this country. I think it's very important, and that is really covered extensively in your readings. So the point of the ACA, the original point, was to make sure everyone had access to health insurance in the country. We know that Medicare covers those folks who are 65 and older for the most part. We know that Medicaid covered everybody who had certain income limits and people with disabilities. So we have this kind of middle group who were above the poverty limit but below age 65. Now classically, and how we a lot of times envision this in our country, is that those folks are covered through employer-based insurance, which is basically you get insurance from your employer at your job. But we know that not everyone was covered by employer-based insurance. It was historically really difficult to get insurance outside of that employer relationship. Sometimes you'd have to be part of a group, or you would have to buy insurance kind of individually from a company. It was really difficult to compare different companies and what they offer. So the ACA really put in this federal marketplace to create this alternative to employer-based insurance and have this whole middle group of folks in the country have access to insurance. Because we're talking about that whole middle group this week, this is why I put both the marketplace and employer-based insurance together. In your readings, you have quite a bit about how these two programs work. But to really understand the nitty-gritty of the marketplace and employer-based plans, we're going to actually talk about what they look like and how they work. Just a quick caveat. I always get emails from students that say, well, if we have the federal marketplace now, why don't employers just stop doing employer-based insurance and then we just have the marketplace? Well, that has been suggested, but so far, a lot of employers and insurance companies weren't behind that idea. So at this point, as an employer, you could tell your employees to go get your insurance on the marketplace, but if you're big enough, you might have to pay a penalty to the federal government. Also, you have to consider that this is a really nice benefit for employees. Often employees look at this benefit as part of their reasoning for taking a job. Also, ending health insurance might cause some employees to leave. So there is a reason why we haven't shifted away from employer-based insurance directly over to the marketplace yet. So I want to start with some really important terminology that you need to know if you're going to understand employer-based insurance and the federal marketplace. A lot of public health students understand the macro of public health, but don't understand the micro parts of public health. So I want to dedicate a little time to this week. If you're already very familiar with these terms, this should be painless. I will make it quick. So the deductible is the amount of money that an insured person needs to pay before their insurance coverage starts paying. $2,000 is kind of an example of a deductible. However, now in 2018, deductibles might be around $6,000 or $7,000. It's the amount of money that you need to pay before your insurance kicks in. Coinsurance. This is a percentage of cost that the consumer pays after you've paid your deductible. So say you've finally paid off your $6,000 deductible. Well, your insurance might say after that you only pay 10% and the insurance company pays 90%. That's a co-insurance. Now, a co-pay is like a co-insurance, but it's usually a fixed cost. So it might be you go to the doctor and you pay $10. Or you might go get a pharmaceutical and it's $5. So copay is like a co-insurance, it's just a fixed cost. Now, the out-of-pocket max is a really important term. It used to be that we had out-of-pocket maximums, but they had a whole lot of exceptions, meaning they weren't that great indicator of how close you were to meeting your max. Nowadays, out-of-pocket max is a lot more finite. So the out-of-pocket max is the maximum amount of money you pay after you pay your deductible and your coinsurance and your copayments that you will spend in a covered year. So if you get really, really sick or really, really hurt, your out-of-pocket max is that number that is finite that you would have to spend that year. There are still some exceptions to it, but it is a good indicator of how good health insurance is. Prescription drug tiers. It used to be that when you went to the pharmacy to pick up your prescriptions, you might not know exactly how much you are going to pay for your prescription. A lot of plans have prescription drug tiers, which create these co-payment scales for different drugs. And you can see that often those are tiers that are maybe $5, $10, $20, $50. Maybe it starts at $20, goes up to $100. There's usually a specialty tier that's $300 or $500. And those are essentially co-pays for prescription drugs. Now, here's a really important part of insurance plans: in-network. If you're in-network, usually there's a whole set of costs that you have to pay. Now, if you're out-of-network, that means that there's a whole different set of costs that you have to pay. How do you know as a consumer what's in-network and what's out-of-network? Well, usually insurance companies will make that information readily available to you. For instance, if you went on Harvard Pilgrim, Aetna, or Blue Cross or Blue Shield, they'll have a button that you can click on their website and find out who's in network and who's out of network. The distinction between the costs in network and out of network can be confusing sometimes, because you might have certain practices in one building that are covered but others are not. It's really important because such things like an out-of-pocket max might not apply if you're getting your care out of network. So, let's look at an example. This list is a very good insurance plan, so don't use this as the barometer for every other insurance plan. However, this might be something that you see if you went on the federal marketplace and looked for an insurance plan, or if you were picking out a health plan for your employees. You might get a list of, 20 of these and be able to compare them. If you've never seen one of these before, I'm going to go through this with you so you feel comfortable seeing these. As a public health student and a future public health professional, it's important you know how to look at this and be able to decipher what exactly it means. So let's start with that blue arrow. The blue arrow is pointing at the deductible on the top line. Your deductible on this plan says $500, $1,000, and then $2,500 and $5,000. Now, often what these two columns are is in-network and out-of-network. So you can see the yellow arrows down at the bottom of the screen. The first column is what is covered, the second column is in-network, and the third column is out-of-network. So what the deductible is saying is your individual deductible is $500. That's how much you would pay before insurance kicks in. If you had a family plan, that deductible goes up to $1,000. And that's if, you're adding your wife, your husband, your children, your partner, whoever. Now the next column, $2,500 and $5,000 is quite a bit more. that usually indicates that it's out of network. So if you're getting all your care out of network, you have to pay $2,500 deductible before the insurance kicks in, rather than $500. So quite a stark difference. Coinsurance. So look at that purple arrow. The coinsurance on this plan is really, really good, and you're unlikely to see this on most plans on the market. So it's 0% after deductible if you're in network. That basically means you don't have to pay anything after you've met your deductible. Out of network, it's 20%. So that means the insurance would kick in 80% if you were getting care out of network. Coinsurance, the green arrows. So the coinsurance for a single person on this plan is $1,000, $2,000 for a family. What that means is after you've paid your $500 deductible, you're probably going to have to pay some other things if you need health care, and the limit of those things is $1,000. So if you go down to your out-of-pocket max, the red arrow, you can see that if you add your deductible together with your coinsurance limit is $1,500. That means you'll pay your deductible, and if you paid all your coinsurance because you needed multiple things that cost money, the out-of-pocket max that you would pay would be $1,500. This is a really good plan if you haven't noticed. A lot of plans that you will see nowadays, those numbers would be much higher. $6,000, $7,000, $10,000, $12,000 higher. So, let's go down to the pink arrow. Prescription drugs. Now these are called prescription drug tiers, but they are basically copays. So you can see in network, there's $10, $30, $50, or specialty is $100 or $300. So that means they've grouped all the pharmaceuticals out there, pretty much, into these categories, and each drug has a copay. Now say that you have a chronic health condition, and starting in January of the year, you have really expensive prescription. Let's say it falls into the $300 copay category. So first week of January, you go to get your medication and they say it's a $300 copay. Okay, well you pay your $300 copay. Now you've got 11 months left. Well, because your out-of-pocket max is $1,500, you won't have to pay $300 for the rest of the year. You will only have to pay $300 until you get to that out-of-pocket max, right? Okay, so there's other things on here that you can check out. When you see copay, remember that is basically a coinsurance but a set amount. Emergency rooms, $200. MRI, CT, and PET scans are $200. So if you needed one of those immediately after you got your insurance, you probably have to pay the full $200 because your deductible is only $500. So that would probably come completely out of pocket. Now, if you needed multiple services throughout the year and you go above that $500, well, now you just have to worry about what else you have to pay until you get to that out-of-pocket max. So why am I teaching you this really confusing stuff? Because you really can't analyze public health policy unless you understand how these plans work. Now, copays, coinsurances, these are all in Medicare and Medicaid. So if you're wondering why I didn't teach you this earlier, it's because they're a lot more important really on the federal marketplace and in employer-based plans. Because as public health professionals, you might end up being in a position where you need to pick this either for you or for someone else. Not to mention, as public health students, you need to understand the nitty-gritty rules of healthcare, as well as understanding macro health policy. Not to mention, this class is about healthcare financing too. Not to mention, it's actually fun to understand how this stuff works, right? So, let's use our tools and look at employer-based healthcare. costs. Well, we know the cost of employer-based healthcare is probably pretty high. It matters how many employees someone has, and it matters what insurance is available in the area. Cost to the employee can also be high. It can be different for every employee at one organization as it is for another. Usually employees all pay the same rate under the employer. However, if you move from employer to employer and you have the exact same insurance company, you might have a different insurance rate. Quality. Well, the ACA put in some quality rules when they created the marketplace, and also tried to create some quality when they put new regulations on employer-based insurance. But the key tool to use on these is access. So the whole point of the federal marketplace was to grant access to people who couldn't get health insurance through employer-based plans. In regards to employer-based plans, access is a real problem, right? If you don't have a job, or you don't have a job that provides insurance, you used to not be able to get insurance. Well, with the federal marketplace, now you can. So as you can see, employer-based insurance and the federal marketplace are very intertwined in thinking about your tools of cost, quality, and access. So this week, you have a discussion post where you get to choose your tool. I'm also putting in a bonus point opportunity this week. I want you to really try and understand the marketplace, the long-term impact that it's going to have on employer-based plans. Do you think we're going to have employer-based plans in the future? Why or why not? As always, let me know if you have any questions, comments, or concerns, and enjoy week 5.